Let's begin with a basic review of cardiac anatomy. You should be familiar with all the labeled structures on this diagram, and if you need to, take a moment, pause, and review this for yourself. And moving forward, we need to understand that the heart consists of chambers and valves. There are 4 chambers, the right and left atria, and the right and left ventricles, that are lined by cardiac muscle, which generates a contractile force pressurizing the fluid within the chambers. The valves serve to ensure that fluid will be moving in the appropriate direction. For example, on the left side of the heart, we have the mitral valve, and upon contraction of the left ventricle and pressurization of the fluid within the left ventricle, fluid will exert force on the walls of the container, and when exerting force on the mitral valve, it will cause it to close. This prevents backflow of blood into the left atria and allows for forward flow of blood into the aorta. When the ventricle relaxes, pressure in the aorta will then exceed pressure in the ventricle, which will cause the aortic semilunar valve to close. And a similar process would occur in the right ventricle. Additionally, we should understand the anatomy of the cardiac conduction system. The SA node, or sinoatrial node, is the pacemaker of the heart, in that it sets the pace and the rhythm of the heartbeat. And a depolarization impulse from the SA node will be transmitted to the atria, leading to atrial contraction, and the atrioventricular node. So we see here in step 2, the SA node is depolarizing, sending its impulse outward to the atria, allowing for their contraction, and to the AV node. Now, an interesting thing happens at the AV node. There will be what's called a conduction delay. Now, this serves an important physiologic function. So remember, the purpose of the atria is to fill the ventricle with blood. Because of this, the atria must contract before the ventricle contracts. As we reviewed in the previous slide, once the ventricle contracts, the AV valves will close, and any contraction by the atria will be futile and will actually damage the walls of the atria. So the atria needs to contract first. In order to allow this to happen, there is a delay in the depolarization impulse that occurs at the AV node. Following this delay, as we see in step 4, the AV node will transmit the impulse down the bundle of His to the apex of the heart, and then back up through the Purkinje fibers. Importantly, as the Purkinje fibers signal the ventricle to contract, the ventricular contraction will occur from the apex, or the tip of the heart, toward the base. So if you think of the heart as a triangle or a pyramid, down here is the apex, and the contraction will proceed from the apex toward the base, again serving a physiologic function. If you think about squeezing a tube of toothpaste, you would squeeze it from the bottom to eject toothpaste out the top. In the same way, the ventricles initiate their contraction from the bottom so that they can squeeze blood out the base where the aorta and pulmonary arteries are. So let's understand how this cardiac conduction system actually functions. So we've said that the SA node is the pacemaker of the heart, and it's said to be the pacemaker because it has autorhythmicity. It will generate its own rhythm for the heart to contract in a normal fashion. It does so through what's known as the funny current. The funny current, shown here in orange, is the influx of cations, predominantly sodium, that occurs once the cells of the SA node reach their resting membrane potential. This occurs automatically at this point and generates the rhythm of the SA node. Once threshold is reached, however, there is a rapid influx of calcium, allowing for a depolarizing upstroke. And then the repolarization phase, like many other cells, is controlled by potassium. So while the SA node generates a steady rhythm, we know intuitively that the heart can beat at a variety of rates. For example, when you're exercising, the heart will be beating fast, and when you relax, the heart will beat slow. So there must be some kind of input on the pacemaker cells of the SA node and indeed that's done through autonomic regulation. And from what we've learned up to this point, you should already know which branch of the autonomic nervous system will increase the heart rate and which branch will slow the heart rate. So sympathetic inputs will lead to an increase in the heart rate, whereas parasympathetic will lead to a decrease in the heart rate, which makes sense. Fight or flight, you need a fast heart rate. Rest and digest, you'll have a slow heart rate. So that's the SA node, but how about the contractile myocytes themselves? It turns out they also have a rather unique action potential. In this case, the depolarizing upstroke is mediated by the influx of sodium that occurs when the cell reaches threshold potential. But what's interesting about the contractile myocytes is that they have a plateau phase where calcium channels remain open. This allows the cell to remain depolarized for a greater period of time, which allows for a sustained contraction. Upon the closure of calcium channels, there will also be opening of potassium channels, which will provide a repolarizing downstroke to the action potential. So having learned a little bit about the conduction system of the heart, we can now turn to the electrocardiogram, or EKG. So the EKG measures the sum of the myocyte depolarization and repolarization. It's essentially the grand total of all electrical activity occurring in the heart at any given time. In the cardiac cycle, the first thing to occur would be the depolarization and contraction of the atria, which is denoted by the P wave. After some delay, the ventricle will depolarize and contract, which is denoted by the QRS complex. Again, after delay, the ventricle will repolarize and relax, which is denoted by the T wave. And if you'll notice, there's only one thing we skipped, which is the atrial repolarization, but it turns out it's hidden somewhere within the QRS complex, and therefore we don't need to worry about it. So let's take what we've learned so far. I've drawn on the left a normal EKG, and below it an abnormal EKG. So in the EKG that I've labeled abnormal, where do you think the most likely site of pathology is? Take a moment, pause, think about it. So in this case, the site of pathology would be at the AV node. So in these two examples, none of the waveforms themselves have actually changed. The P wave has stayed the same, the QRS complex has stayed the same, and the T wave has stayed the same. The only difference comes in the interval between atrial depolarization and ventricular depolarization. And we call this the PR interval. So with normal atrial contraction, we can assume that the SA node and the atria are functioning properly. We also see that the QRS complex is normal, so we can assume that the ventricles are also functioning normally. The only difference would be in the time between atrial contraction and ventricular contraction, at which point the impulse must travel through the AV node, the bundle of His, and the Purkinje fibers. So we can pretty confidently say that the pathology must be somewhere in there, and of the options, AV node would be the correct answer. So this is a phenomenon known as heart block. Now let's take a look at the mechanical properties of the heart. We'll do so by analyzing the relationship between ventricular pressure and ventricular volume, known as the cardiac PV loop. So you see here I've labeled this left ventricular pressure and left ventricular volume, but understand that the same principles are in effect in the right ventricle, albeit at lower pressures. So at our starting point here in the bottom left, the ventricle is just beginning to fill with blood. And we know from cardiac anatomy that for the left ventricle to fill with blood, the mitral valve must be open. So with an open mitral valve, most of the filling of the left ventricle takes place in a passive process, with blood simply trickling in from the atria. Because of that, pressure stays relatively constant, and we have what's known as an isobaric, or constant pressure, filling process. Now, toward the end of left ventricular filling, the atria will contract, providing an atrial kick and slightly increase the left ventricular pressure, as we see toward the end of this. Also around this time, the left ventricle itself will begin to contract and begin to increase the pressure within. Upon ventricular contraction and an increase in pressure above that of the left atria, the mitral valve will close. So at this point, the mitral valve is closed. The aortic semilunar valve has not yet opened, so there's nowhere for blood to go. Thus, we have an isovolumic or constant volume process. The ventricle is contracting at this point, so pressures are increasing. Now, with enough contraction and with enough increase in pressure, the blood within the left ventricle will exceed the pressure of the blood within the aorta. And at this point, the aortic semilunar valve will open. Once the aortic semilunar valve opens, blood is ejected from the ventricle. Over the course of this ejection, eventually, the pressure within the left ventricle will fall below the pressure of the aorta. And at this point, the aortic semilunar valve will close. So now we have a closed aortic semilunar valve, and we have a closed mitral valve. With both valves closed, again, there's nowhere for any blood to go, so the volume will be held constant. Again, we have an isovolumic or constant volume process, but in this case, we're now relaxing the ventricle, so pressure is decreasing. And again, pressure will decrease until the pressure within the atria exceeds the pressure within the ventricle, and the mitral valve will open. And then we're back at our starting point. So we can actually label this entire diagram, starting with the opening of the mitral valve, isobaric constant pressure filling, left ventricular contraction to close the mitral valve, increase in left ventricular pressure, or isovolumic contraction, until the aortic semilunar valve opens, and then ejection of blood until blood in the aorta exceeds the pressure of blood in the ventricle, at which point the aortic semilunar valve will close, the ventricle will relax, and the mitral valve will open again. But there are also more variables that we can consider here. The maximal volume that the ventricle will obtain occurs at a point here. We call this the end diastolic volume. So diastole refers to relaxation. So the ventricle fills as it's relaxing, and once it begins to contract, the mitral valve will close. So the maximal volume it will obtain comes at the end of the relaxation phase, or the end diastolic volume. After diastole comes systole, which is the contraction phase of the ventricle. Aortic semilunar valve will open, blood will be ejected until the pressure within the ventricle falls below the pressure within the aorta. This we call end systolic volume because it occurs at the end of the contraction phase, or at the end of systole. All the blood that was ejected between end diastolic volume to end systolic volume is the stroke volume. So we can say that stroke volume equals end diastolic volume minus end systolic volume. And then the final variable to consider would be work. So if you've studied physics at this point, or more specifically thermodynamics, you may remember that work equals P delta V, pressure times a change in volume. So in this case of the cardiac pressure volume loop, the work will be the entire area enclosed by the PV loop. That is all the work that the heart is doing. Again, pressure times the change in volume. So let's apply some of this information. How does the cardiac work change with hypertension or high blood pressure? Pause and think about it. So cardiac work will increase with hypertension, and intuitively this is pretty easy to understand. When the heart is pumping against a greater blood pressure, it will need to do more work. And we can see this reflected in the pressure volume loop. With high blood pressure, the ventricle needs to achieve a greater pressure to open the aortic semilunar valve. The entire volume of this extra space is the additional work that is being done by the heart. Now, with sustained hypertension and untreated hypertension, patients will often develop heart failure, and that occurs when the heart can no longer keep up with this additional workload. So we know that work equals pressure times a change in volume, so there are two variables to account for. Here we've raised the pressure, and if the heart is to get back to a workload that it can tolerate, it can either decrease the blood pressure or it can decrease the change in volume. So in a hypertensive patient who is beginning to develop heart failure, the decrease in the volume change will then bring work back to its baseline point, which the heart can tolerate. However, this changes the stroke volume by increasing the end systolic volume, which obviously has adverse effects on the patient with heart failure. So that brings us to the other determinants of stroke volume. The one we've just discussed is afterload, which is essentially equivalent to the blood pressure. Afterload is what the heart is pumping against in order to eject the blood. So preload is the amount of blood in the heart as it begins to contract. That's the end diastolic volume. This is all the blood that we're returning to the heart in preparation for the next heartbeat. So by increasing the end diastolic volume, we can increase the stroke volume. And this brings us to a related point, which is called the Frank-Starling mechanism. So the Frank-Starling mechanism states that with an increase in preload, the cardiac myocytes will be stretched to a more optimal length, which will actually lead to an increase in contractility. So end diastolic volume will increase, and due to an increase in contractility, end systolic volume will be unchanged, which will result in a greater stroke volume. The third determinant would be the contractility itself, which can be mediated by the sympathetic and the parasympathetic nervous system. So the fight or flight reflex in the sympathetic nervous system will act to increase the contractility of the heart to provide a greater cardiac output. So increasing the contractility of the heart will decrease the end systolic volume, or the blood left over after the contraction, which will act to increase the stroke volume. So now we get to put it all together, and we're going to study the cardiac cycle. So a cardiac cycle is one complete cycle of contraction and relaxation. By convention, it begins with atrial contraction, and it ends just before the next atrial contraction. If you understand this diagram, you pretty well understand the mechanics of cardiovascular physiology. And luckily, this is all just application of what we've already learned. So let's walk through it together. We see the orange line here represents atrial pressure. So the ventricle will fill as long as atrial pressure is greater than ventricular pressure. And this increase in atrial pressure is the atrial contraction. This tops off the ventricle, preparing it to contract. Once the ventricle contracts, the ventricular pressure quickly exceeds the atrial pressure, which closes the atrioventricular valve. If we're talking about the left ventricle, this would close the mitral valve. Now, with both valves closed, we have a rapid increase in pressure, but no change in volume. So this is our isovolumic contraction. Once ventricular pressure exceeds aortic pressure, the aortic semilunar valve will open, and we will begin our ejection phase. Blood will eject until the ventricle relaxes, and the aortic pressure now exceeds ventricular pressure, which will cause closure of the aortic semilunar valve. Again, with both valves closed, we have a rapid decrease in pressure without a change in volume until ventricular pressure falls below atrial pressure, at which point the AV valve will again open, allowing for ventricular filling. then the cycle will repeat itself. We can also see here the auscultogram, which is what you would hear if you were listening with a stethoscope. Really just denotes the closure of each valve. And then we can go one step further and we can add the EKG tracing to what we would expect to see within the cardiac cycle. So remember, the P wave should be just before the atria contract, as it represents atrial depolarization. Similarly, the QRS complex should occur just before the ventricles contract. The T wave occurs just before the ventricles relax, and then the cycle will repeat itself. So hopefully you've seen by this point that mastering a few basic concepts can teach you a great deal about the complexity of cardiovascular physiology. And that concludes the lectures on the cardiovascular system.